Hey everybody, welcome to today's PermanenteDocs Chat. It's actually our last chat of 2022, but don't worry, we'll be back in 23, but bigger and better than ever. I'll talk about that later. I'm your host, Alex McDonald. I practice family and sports medicine here in Fontana, California, as most of you know. Thanks all for joining in for wherever you may be listening or watching. It's December 1st was World AIDS Day, and as a result, I'm really excited to welcome our guest today, Dr. Colin Fields, who is a family physician at the Washington Permanente Medical Group. He's also the medical director of their government relations and public policy program, as well, and most importantly, the quality medical director of their HIV and PrEP program. So we are going to jump right in. If you guys have questions, please feel to drop them in the chat or post them in the comment section if you're streaming this on Facebook, and we'll go from there. So, Dr. Fields, thank you so much for joining us. Let's just jump right in. So tell us who you are and what you do.
Well, Colin Fields, he, him pronouns. Like you said, I'm a family physician here at Washington Permanente Medical Group. For the most part, I practice in Seattle at our Capitol Hill campus, but I also rotate to other clinics outside of Seattle where I see people living with HIV. And then I also work a lot with gender diverse patients, see a lot of transgender members here in Washington.
Great. Well, tell us what you've been seeing recently with gender diverse patients and HIV and HIV care. We know that pandemic has upended a lot of the way we provide care as well. Anything specific regarding this patient population?
Well, I think that there's actually a couple of ways to answer that question. One would be the effect of the pandemic on HIV care, but I also think that it's the inverse of that, the effect that HIV care had on the pandemic itself. And I'll answer the latter first, which is, in the 1980s, 1990s, there were a lot of activist groups like ACT UP, which advocated for early access to medications that were investigational in order to reduce the risk of death potentially from HIV or an at that time in untreatable disease. And as a result of that the FDA developed emergency use authorization. And so, we benefited from ACT UP, even if that wasn't the intent of the time. But by being able to have access to, like, in an unprecedented way to vaccines for COVID-19. So I think that HIV had, a lot of consequences for the pandemic. And then I think that the pandemic's effect on HIV, I definitely noticed some improvements in some ways of being able to have access to talking with patients via video. When you have patients that are in lots of different geographic areas that may not have a lot of specialists in that particular field, it's been really nice to be able to connect with patients virtually throughout the year when I'm not there physically. Mm-hmm. And then when it comes to PrEP or pre-exposure prophylaxis, the pandemic definitely had an effect with people social isolation and stopping their PrEP prescriptions. And we had a lot of PrEP pauses at that time, but patients after 2020 started to take PrEP again.
Yeah, try saying PrEP pauses 5 times fast. I can barely say it once. Well, that's really interesting. I didn't necessarily know that history about the EUA, emergency use authorization, and the history there. I think that's really a really fascinating point, and we could probably go down the rabbit hole of talking about sort of public health and sort of the how shall I say this politely? The slow degradation of our public health infrastructure really since the 80s, with AIDS and HIV really probably being the last major public health issue since now COVID. I don't know if you would agree with that or not. Or you want to put your health policy hat on for a second and share some of your thoughts there as well.
Well, I think that, we definitely saw during the pandemic that a lot of everybody's resources went towards the pandemic. Right. And I think in terms of public health resources, anything extraneous like HIV or PrEP definitely went towards the pandemic. And I think that had a lot of implications for ability to reach out to patients, the ability to monitor patients who were maybe not engaged in care or did not have suppressed viral loads. And so I think that there was definitely social impact, especially for HIV, on not having a robust network of resources in the public health sector to be able to manage such a huge emergency at the same time that you're managing all the other chronic diseases.
Yeah, I think that certainly is only so many resources to go around. That certainly makes a lot of sense. I was sort of reflecting when we were preparing for this talk. When I was in medical school 20 something years ago, in fact, I started medical school 20 years ago, exactly this year. We heard a lot. There was more public awareness about HIV and AIDS, and it's really sort of fallen to the back burner at this stage. And the impact, obviously, of HIV and AIDS in our communities and the health of our nation is still prevalent, but is not nearly as high in sort of the awareness of our populations and just the public in general too. Can you share some thoughts about how people are now, you mentioned, treatable versus curable prior. Can you tell us about some of the advances regarding HIV and the treatability, but also still how it's impacting the health of our nation and our communities at this point?
Sure. So, I think this generation, or one of our younger generation, Gen Z, was born after 1996, and the first medications that were fairly tolerable and effective for HIV, really the marker for that was 1997. And I think that once we started having like the cocktail at the time, and we started seeing less effects of HIV in hospital systems, in clinical systems, that this news story kind of ended. But, we still have about 35,000 new cases of HIV in the United States every year. We still have about 1.2 million people living with HIV in the United States. And so there's still a lot of transmission of HIV, and HIV was never really given the definition of a pandemic, but I don't know how it's not a pandemic. It still has ongoing transmission, and we still have the challenges of breaking that transmission in order to reduce the overall viral load within the public. Because for HIV, treatment is really prevention. We know that people who are treated for HIV and have undetectable viral loads are unable to transmit virus. So we have a pathway to kind of eradicate HIV, but we still don't have a robust ability to do so.
Yeah, no, that's a really interesting point. One of my colleagues actually, 2 years ago, when we were sort of in the throes of the pandemic, actually wrote a really interesting article and a reflection back to when they were in training in the 80s, actually, and how HIV and AIDS really, especially when it first became more prevalent, nobody knew exactly what was happening. And a lot of those same concerns and fears that happened with COVID happened when HIV and AIDS really first was recognized in the 80s. And a lot of us have sort of forgotten about that, I think, at this point, 50 years later.
I had a number of patients who I think were fairly triggered by the onset of the pandemic. I remember when the boat that docked in San Francisco early in the pandemic, there were a lot of patients who really were quite triggered by that event and the need to try to sequester people from the public. So yeah, I think that we all lived through a really consequential historical moment, but for some of these patients, they lived through yet another pandemic. So that was interesting to experience with them.
Yeah, absolutely. Well, we have a question here in the chat. What's the one thing that you wish young people knew about HIV, and how best to have physicians be the ones to offer that information or that piece of advice?
Well, I had a patient it was a couple of years ago now, who was 22, and he asked me does untreated chlamydia lead to HIV? And I just was really taken aback by that, because I think that we've all had a lot of experience now in what viruses are, but I think it's important to just educate your patients about the availability of PrEP, to screen them for if they should be offered PrEP. And I think it's really important to break down some of our internal biases about this. I think when we talk about PrEP, we always think about it as for men who have sex with men.
Mm-hmm.
But PrEP should be offered to heterosexual people too, especially if they've had a recent STD or they're having multiple unprotected partners. They too are eligible for pre-exposure prophylaxis to help reduce their risk of HIV. And I think it's really important too that we start educating more of our pediatric and adolescent and family medicine providers about the conversations around pre-exposure prophylaxis in teens and young 20-somethings, people who have recently started becoming sexually active. A lot of times we have the conversation around birth control, but I think that we really need to have that knee-jerk reflex about pre-exposure prophylaxis too, and having easy conversations with them about the availability of that type of medicine to reduce their risk of HIV.
That actually is the perfect segue into my next question, actually. So you must have been reading ahead. And by the way, for the record, no, chlamydia does not cause HIV, just to be clear, although this audience probably knows that. So the USPSTF, or the United Service Preventative Service Task Force, recently came out with a new recommendation regarding pre-exposure prophylaxis. Can you share these recommendations? And just, again, you already touched on this, sort of the importance of educating physicians and patients regarding PrEP. I have a lot of patients who are on PrEP, many of whom ask, actually, particularly, it's in the men who have sex with men population, probably tends to be a little bit more common knowledge. So they tend to come in asking for it. But I have a lot of heterosexual individuals who are engaged in high risk behavior, and we have that conversation. And I've started them on PrEP right here in my family medicine office too. So it's really, when I first heard about it, I was kind of scared, but one of my colleagues kind of helped talk me through it. I did attended a couple CME sessions, and it's really pretty straightforward. So tell us about the USPSTF recommendations.
So the USPSTF recommendation is actually a grade A recommendation, which I feel like for USPSTF, grade A is like breathing and drinking water. So I feel like it's unusual to get a grade A recommendation from USPSTF. I don't know if I could say exactly the criteria, but really it's recommending people who have had recent STDs, specifically gonorrhea and syphilis, have sexual partners of unknown status, sexual partners who are living with HIV but do not have an undetectable viral load, people who are sharing intravenous drugs, and then people who are having more than 3 partners in a year. So it's actually, people who may be exchanging sex for money or other things. So it's actually quite a fair number of people, and it's not as necessarily specific to just MSM, although men who have sex with men should definitely be screened for eligibility for PrEP.
Yeah, no, I mean, I think that's the thing. Grade A recommendation means you should absolutely do this virtually all the time. And so I think it's just incorporated into our thought processes as primary care physicians. We're kind of going down the list, and this should probably be one of those things. I think a lot of times, particularly with the residents I work with, we teach them to sort of, ask if they're sexually active with men, women, or both. And then they give us the answer. We don't necessarily go down that road of, okay, then what if they are at higher risk for any number of behavior activities as well too. The White House recommended earlier this month that really, and you kind of mentioned this, to really we have the pathway to sort of end the HIV epidemic in the United States and really around the world. What that sounds like a heavy lift. What really needs to happen to make that a reality?
So there are about 1.2 million people in the United States living with HIV, but there's about 13% of them that do not know that they're living with HIV. And so I think the first one is that we should just have universal screening if possible, health maintenance alerts for people who have not had screening for HIV at least once in their lifetime. And people who are sexually active should be screened more frequently than just once in a lifetime. We did implement some of those here at Kaiser Permanente, Washington in summer of 2022. And we've actually picked up about 2 cases since then as a result of that health maintenance alert. So it does work. I mean, I don't know the number needed to screen, but we have been picking up some cases. We also need to identify people who are at risk of HIV based on their behaviors and offer them pre-exposure prophylaxis like we talked about. But of the people who do know that they're living with HIV in the United States, only about 70% of them are engaged in medical care, and even less are taking antiretrovirals, and even less are fully suppressed. So augmenting those numbers by getting people engaged in care, offering them antiretroviral therapy, and then trying to follow up with them and make sure that their viral load suppresses would be the way of mitigating risk for the public. And fortunately, in the United States, we're seeing a decrease in HIV year over year, but we're not necessarily seeing that risk for other STDs. The rest of them are all going up.
Right,
So,
exactly. Well, and I think that's something that goes back to my earlier comments too about how the younger generations, they don't, they're not too worried about STDs like we did when maybe I won't date myself. I won't date you. I'll date myself. Like when I was a kid, I heard about it a lot in high school, because at that point, that was sort of when, highly heart medications became more available too. So I think it's just an awareness and a bit of a culture shift, I think, for some of our younger individuals as well too.
yeah, and there's a couple of documentaries I think are really great to direct patients to. There, How to Survive a Plague won the Academy Award in 2013, which was a documentary that followed a lot of the members of ACT UP, and it was really well done. So when people are kind of curious, I try to direct them to documentaries like that, to just because it is now kind of a historical marker, and they don't necessarily have all the context for it.
Yeah. What's the name of that documentary again?
It's called How to Survive a Plague.
How to Survive a Plague. All right, I have not seen that. I'll check that out myself for sure. Another question here in the chat here. You mentioned sort of the screening tools we have. You implemented there at KP Washington, and obviously KPing a closed loop system that sort of wraps around the patient for all the different healthcare services is pretty unique. Do you think that Kaiser Permanente is sort of ahead of the curve in the rest of the industry when it comes to screening and treating HIV? And are there still gaps that need to be done? And I guess a third part, which I'll add on, is how can we help sort of lead that charge as well?
I mean, the answer to the first question is yes. I think Kaiser Permanente is always ahead of the curve, and particularly with HIV care. Kaiser Permanente has an interregional group that includes all of the regions and their HIV teams. I think that Kaiser Permanente has a robust ability to collect data, and as such, we know that our viral load for the patients who are in our system is pretty well suppressed. I think that one of the best things that we're able to do is to demonstrate our abilities to implement programs and the data that we're able to collect as a result to show the outcomes. And so I think that we can lead by showing other systems what's been effective for our treatment for our patients.
Yeah, that makes a lot of sense. The next question here is talks a bit about social media and sort of my interest and my passion of social media too. My dovetail or come through here. You wrote a column recently talking about reaching out to this next generation about raising awareness, about understanding of the importance of reducing sexually transmitted diseases and PrEP as well. Tell us more about kind of some of the things you talked about in that article, and why do you think this is important?
I think it's about meeting people where they're at. I don't think that we have in our own system the most robust presence on social media. I think that it would be worthwhile to develop just pretty quick snapshots of what particular diseases like HIV are and what might put one at risk, and then what you could do to help alleviate that risk. I think it would be a good way of disseminating information to a population that isn't necessarily going to get their information from other sources. So we might as well go to them with useful vetted, evidence-based recommendations that we could just boil down into quick snapshots.
Right. Reaching people where they are versus waiting them to come to us. And we may be waiting a very, very long time with some of our younger patients as well, too. Great. Well, this has been really helpful and really informative. I appreciate you taking the time. Last question here, unless I know someone dropped something in the chat last minute here. What makes you most proud to be a Permanente physician?
Well, I mean, I came to Kaiser Permanente because I wanted to operate in an integrated system. I really appreciate the robust knowledge of my colleagues. And it's not just my colleagues here in Washington, it's really around the country. I mean, I think it just really leads to a much more substantial understanding of what's happening in medicine. And I think that it shows in our ability to deliver care to patients.
Yeah, no, very, very well said. I wholeheartedly agree. Well, Dr. Fields, thank you so much for joining us today. I really appreciate your time.
Yeah, thank you for having me.